Hey guys, this is FixerMed. Welcome back to my ECG Skills Builder Workshop, where I will be covering all of the fundamental knowledge and skills you will need to read and interpret an ECG in a quick and effective manner. This will be part 13 of my multi-part video series of doing so. Today we will be looking at various types of heart blocks and how they can be interpreted on an ECG. Without any further delay, let's go ahead and get started on today's content. Alright, let's start off with a brief introduction. Heart block occurs when the electrical signals that control the heartbeat are delayed or blocked as they travel from the atria to the ventricles. This can lead to a variety of symptoms, including fatigue, dizziness, and fainting. There are three main types of heart block: first degree, second degree, and third degree. Let's take a look at SA node blocks. They are characterized by a complete pause of one heartbeat, appearing as a dropped beat on the ECG. They can also occur occasionally in normal patients, but may indicate underlying sinus node dysfunction in others. As seen on the sample ECG to the right, we have to remember that when examining SA blocks, the RR interval measurement is within plus or minus two small boxes. Let's take a look at sinoatrial arrest. It is characterized by a complete absence of P waves for a period of time, leading to a pause in the heartbeat. This pause can be temporary or sustained, depending on the underlying cause. As seen on the sample ECG to the right, we have to remember that when examining sinoatrial arrest, the RR interval measurement is greater than plus or minus two small boxes. Let's take a look at first-degree AV blocks. Every P wave is followed by a QRS complex, but the PR interval is prolonged, greater than one large box on an ECG. It is often seen in healthy individuals and may not require treatment. It may be associated with conditions like rheumatic fever. An example of a first-degree AV block can be seen on the ECG to the right. Let's take a look at second-degree AV blocks. There are three major types of second-degree AV blocks, which I will go through one by one with you guys here, followed by some visual examples on the next slide. Mobitz type 1, Wenckebach, progressive lengthening of the PR interval until a P wave is not conducted, followed by a shorter PR interval, may not require treatment. Mobitz type 2, constant PR interval, but some P waves are not followed by QRS complexes, may require a pacemaker. 2, 1 block, 2 P waves for every QRS complex, may need temporary or permanent pacemaker. Alright, here are some visual examples of second-degree AV blocks. As seen in the Mobitz type 1, Wenckebach block, progressive lengthening of the PR interval takes place until a P wave is not conducted, followed by a shorter PR interval. As seen in the Mobitz type 2 block, there is a constant PR interval, but some P waves are not followed by QRS complexes. As seen in the 2-1 block, there are 2 P waves for every QRS complex. Let's now take a look at third-degree AV blocks. There's a complete block of signals from atria to ventricles. P waves and QRS complexes are independent, with no relationship between them. Requires a permanent pacemaker, often caused by fibrosis rather than ischemia. A visual representation of a third-degree AV block can be found on the ECG to the right. Let's now take a look at bundle branch blocks. They often occur when electrical impulses are delayed or blocked in the bundle branches, leading to a wide QRS complex. There are two types of bundle branch blocks: the right bundle branch block and the left bundle branch block. In a right bundle branch block, a RSR pattern can be observed in the V1 to V2 leads, may be seen in conditions like atrial septal defect, ASD. In a left bundle branch block, a RSR pattern can be observed in the V5 to V6 leads. A W pattern in V1 and M pattern in V6 can also be observed. It also may be associated with aortic stenosis, ischemia, or acute myocardial infarction. I will follow up this slide with some visual aids in an ECG format to help you understand how they may manifest. Here are some visual aids to help you guys out with bundle branch blocks. In a left bundle branch block, RSR pattern can be observed in the V5 to V6 leads. A W pattern in V1 and M pattern in V6 can also be observed. While in a right bundle branch block, a RSR pattern can be observed in the V1 to V2 leads, may be seen in conditions like atrial septal defect, ASD. Let's take a look at fascicular, HEMI, blocks. These are blocks within the bundle branches affecting specific fascicles. They can cause axis deviations on the ECG. Left anterior fascicular block is often visualized through left axis deviation. Left posterior fascicular block is often visualized through right axis deviation. Bifascicular block is often visualized through right bundle branch block and through either left anterior or posterior hemiblock. Trifascicular block is often visualized through bifascicular block and through first-degree AV block, which is essentially a complete heart block. I'll be going through some visual aids for these blocks in the next few slides to show how they may be expressed on ECGs. All right, here are the visual aids for left anterior posterior fascicular block and left posterior fascicular block. Left anterior fascicular block is often visualized through left axis deviation. Left posterior fascicular block is often visualized through right axis deviation. All right, here are the visual aids for bifascicular block and trifascicular block. Bifascicular block is often visualized through right bundle branch block and through either left anterior or posterior hemiblock. Trifascicular block is often visualized through bifascicular block and through first-degree AV block, which is essentially a complete heart block. Some additional clinical considerations to keep in mind. Left bundle branch block can indicate severe underlying heart disease and may require a pacemaker. Left axis deviation with right bundle branch block can suggest severe conductive tissue disease and may also necessitate a pacemaker. Treatment for heart block depends on the type and severity and may involve medication, pacemaker implantation, or lifestyle changes. Atropine increases heart rate by blocking the vagus nerve's effect on the SA and AV nodes. Used in emergencies or as a bridge to pacemaker therapy, isoproterenol stimulates beta-adrenergic receptors to increase heart rate and contractility, used cautiously due to potential side effects. Dopamine or epinephrine may be used in situations with low blood pressure alongside heart block. Mobitz type 2 may require atropine in acute settings to temporarily increase heart rate. 2. 1 block may require atropine or isoproterenol as a temporary measure. All right, guys, now that we have covered all of the content, let's go ahead and take a look at some questions to review the knowledge you have gained so far. A 68-year-old male presents to the clinic with complaints of fatigue, dizziness, and occasional fainting spells. An electrocardiogram, ECG, reveals a consistent PR interval of 240 milliseconds with all P waves followed by QRS complexes. Which of the following is the most likely diagnosis? All right, I think I gave you guys enough time here. I'm going to move on to see what the correct answer is and what the reasoning behind it is. If you need more time, feel free to pause the video. Otherwise, moving on now. The correct answer is A, first degree AV block. This condition is characterized by a prolonged PR interval, greater than 200 milliseconds on the ECG, but with every P wave is consistently followed by a QRS complex. The patient's symptoms of fatigue, dizziness, and fainting can be associated with the slower than normal electrical conduction through the AV node. All right, let's go ahead and see why the other answer choices are incorrect. The incorrect choices can be explained as follows. B, second degree AV block, Mobitz type 1. This type of heart block would show a progressive lengthening of the PR interval until a P wave is not conducted, followed by a shorter PR interval, which is not described in this scenario. C, second degree AV block, Mobitz type 2. This type would have a constant PR interval, but some P waves would not be followed by QRS complexes, indicating a more severe block than what the patient is experiencing. D, third degree AV block. This is a complete block of the electrical signals between the atria and ventricles, resulting in independent P waves and QRS complexes with no association. E, sinus arrest. This condition would show a complete absence of P waves for a period of time on the ECG, which is not consistent with the presented scenario. All right, now that we have covered this question, let's move on to look at the next question. A patient's ECG demonstrates a repeating pattern where there are 2 P waves for every 1 QRS complex, and the PR interval remains constant. What type of heart block is this most consistent with? All right, I think I gave you guys enough time here. I'm going to move on to see what the correct answer is and what the reasoning behind it is. If you need more time, feel free to pause the video. Otherwise, moving on now. The correct answer is D, second degree AV block, 2, 1 block. This specific type of heart block is characterized by a consistent ratio of 2 P waves for every QRS complex. The PR interval also remains constant, differentiating it from Mobitz type 1, where the PR interval progressively lengthens. All right, let's go ahead and see why the other answer choices are incorrect. The incorrect choices can be explained as follows. A, first degree AV block. This type only shows a prolonged PR interval, but all P waves are followed by QRS complexes. B, second degree AV block, Mobitz type 1. This type exhibits a progressive lengthening of the PR interval until a P wave is not conducted, followed by a reset with a shorter PR interval. C, second degree AV block, Mobitz type 2. This type has a constant PR interval, but some P waves are not followed by QRS complexes without a consistent ratio like in a 2-1 block. E, third degree AV block. This involves a complete block with no association between P waves and QRS complexes, unlike the Fix2-1 relationship seen in the scenario. All right, now that we have covered this question, let's move on to look at the next question. A 72-year-old woman with a history of hypertension and aortic stenosis presents with worsening fatigue and shortness of breath. Her ECG reveals a wide QRS complex with a characteristic W pattern in lead V1 and an M pattern in lead V6. Which of the following is the most likely diagnosis? All right, I think I gave you guys enough time here. I'm going to move on to see what the correct answer is and what the reasoning behind it is. If you need more time, feel free to pause the video. Otherwise, moving on now. The correct answer is B, left bundle branch block. The ECG findings of a wide QRS complex with a W pattern in V1 and an M pattern in V6 are classic for LBBB. Additionally, the patient's history of hypertension and aortic stenosis are risk factors for developing this conduction abnormality. Left bundle branch block can be a sign of underlying heart disease and may require further investigation. All right, let's go ahead and see why the other answer choices are incorrect. The incorrect choices can be explained as follows. A, right bundle branch block. This would present with a different ECG pattern, specifically an M shape in lead V1 and a W shape in lead V6, which is the opposite of what the patient is showing. C, left anterior fascicular block, and D, left posterior fascicular block. These are more subtle conduction abnormalities within the left bundle branch and wouldn't create the wide QRS complex with the characteristic W pattern in V1 and M pattern in V6 seen in left bundle branch block. E, sinus arrest. This refers to a problem with the heart's natural pacemaker and would manifest as pauses in the ECG rhythm, not a wide QRS complex. All right, guys, that is all I have for this video today. If you like this type of content, be sure to leave a like and subscribe for more content like this in the future. Be sure to leave any questions, comments, or concerns down in the comment section below. This is FixerMed signing off. Be sure to have a great day, everyone, and good luck studying as always. Goodbye.